Every day in clinical practice, patients come to the respiratory clinic with complaints. Doctor, I have a cough, chest pain, and fever. I see. Any wheezing or blood in your sputum? Yes, sometimes I wheeze and see blood. Let's investigate that. But here is the real question. How do we move from a patient's first symptom to a precise diagnosis? How do we decide which questions to ask? Which clinical findings matter? Which investigations are necessary? And which findings can actually change our diagnosis? This is where the art and science of pulmonology begins. Welcome to the Pulmocare Pulmonology Clinical Case Masterclass, a journey through 50 challenging respiratory cases. In this series, we will not simply tell you the diagnosis, we will show you how to think, how to approach, how to investigate, how to interpret, and how to make clinical decisions step by step. When a patient presents with respiratory symptoms, our first instinct may be to order a chest X-ray, a CT scan, or a battery of laboratory investigations. But before the investigation comes the patient. And before the diagnosis comes the story. Who is the patient? How old are they? What do they do for a living? Do they smoke? Are they exposed to dust, chemicals, biofuel, or occupational hazards? Have they ever had tuberculosis? Do they have asthma, COPD, or any other chronic respiratory disease? And most importantly, what brought them to us today? Every case begins with a symptom. But a symptom is only the beginning. Take cough, for example. A cough can be acute, subacute, or chronic. A cough can be dry or productive. It may occur at night or be triggered by exercise. It may be associated with fever, weight loss, hemoptysis, or breathlessness. Each additional detail changes the differential diagnosis. The same principle applies to breathlessness. Is it sudden or progressive? Does it occur at rest or only during exertion? Is it with wheezing, chest pain, or nocturnal symptoms? When did your illness begin? What was the first symptom you noticed? What happened next? Characterize your symptoms. Did the patient receive treatment? Did the patient improve? Symptoms recur? Was oxygen therapy required? Was the patient ever diagnosed with tuberculosis, pneumonia, asthma, or COPD? The timeline often provides a critical diagnostic clue. A disease is not just a collection of symptoms, it is a process that evolves over time. Before moving deeper into the diagnosis, identify the red flags. Severe breathlessness, low oxygen saturation, hemoptysis, altered consciousness, chest pain with hemodynamic instability, rapidly worsening respiratory distress, unexplained weight loss, persistent fever, or a patient who is suddenly deteriorating. These findings may change the entire approach. Because sometimes the first diagnosis we need to make is not the final disease diagnosis. It is the diagnosis of an emergency. Is the airway safe? Is the patient breathing adequately? Is oxygenation sufficient? Is ventilation adequate? Is the circulation stable? Before asking what is the disease, we must first ask, is the patient stable? In pulmonology, the environment can sometimes be as important as the examination. Ask about smoking, ask about biomass fuel, ask about occupational dust, silica, asbestos, chemical fumes, bird exposure, mold, and other environmental triggers. A patient may present with breathlessness, but the real diagnosis may be hidden in the workplace. A patient may have recurrent respiratory symptoms, but the trigger may be inside the home. A patient may have progressive lung disease, but the key clue may be an exposure that occurred years ago. Therefore, never ask only, what symptoms do you have? Ask, where do you live? Where do you work? What do you breathe every day? Before touching the patient, look at the patient. Is the patient comfortable? Are they sitting upright? Are they using accessory muscles? Can they speak complete sentences? Is there visible respiratory distress? Now check the vital signs. Respiratory rate, oxygen saturation, heart rate, blood pressure, temperature. Perform a systematic respiratory examination. Inspection, palpation, percussion, auscultation. Wheezing may suggest airflow obstruction. Fine inspiratory crackles may suggest interstitial involvement. Bronchial breathing may indicate consolidation. Absent breath sounds may suggest pleural effusion or pneumothorax. But remember, a physical sign is not a diagnosis, it is a clue, and every clue must be interpreted in context. Before ordering investigations, think, what are the possible diagnoses? For a patient with chronic cough, could this be asthma, COPD, tuberculosis, bronchiectasis, interstitial lung disease, gastroesophageal reflux, or malignancy? For sudden breathlessness, could this be pulmonary embolism, pneumothorax, acute asthma, acute exacerbation of COPD, or acute cardiac disease? The goal is not to guess the diagnosis immediately. The goal is to create a structured differential diagnosis. Think of the common causes, think of the dangerous causes, and think of the diagnosis that must not be missed. Now we move to investigations. But remember one fundamental principle. Do not order a test simply because it is available. Order it because you have a clinical question. Chest X-ray. What do I want to know? Is there consolidation, pleural effusion, pneumothorax, cavity, mass, or another abnormality? If I order a CT scan, what am I looking for? If I perform pulmonary function testing, what physiological abnormality am I trying to identify? If I send sputum, what infection am I trying to confirm or exclude? Every investigation should have a purpose. A report may say pleural effusion, consolidation, ground glass opacity, or pulmonary fibrosis. But the pulmonologist must go one step further. What does this finding mean? Does it fit the patient's symptoms? Does it fit the examination? Does it fit the timeline? Does it support our differential diagnosis? Or does it force us to rethink the entire case? A radiology report is not the final diagnosis. A laboratory value is not the final diagnosis. A positive test is not always the final diagnosis. The diagnosis emerges when history, examination, investigations, and clinical reasoning come together. Now comes the most important moment, the final diagnosis. At this stage, ask yourself, what is the most likely diagnosis? What evidence supports it? What evidence contradicts it? Could the patient have more than one disease? Could there be a serious diagnosis hiding behind a common presentation? And finally, does the diagnosis explain the entire clinical picture? If the answer is yes, we move forward. If the answer is no, we go back. We reassess, we reconsider, and we investigate further. Once the diagnosis is established, management begins. But treatment is not simply a prescription, it is a complete plan. Treat the underlying disease, address immediate threats, assess disease severity. We'll manage any complications by monitoring you closely. It's important to understand your condition. We'll also address risk factors like smoking. We'll plan a follow-up soon. Because the goal of pulmonology is not merely to make diagnosis. The goal is to improve the patient's life. So, how do we approach a pulmonology case? Start with the patient. Listen to the story, define the symptoms, build the timeline. Identify risk factors and exposures, look for red flags. Examine systematically, create a differential diagnosis. Order investigations with a clear clinical question. Interpret every finding in context. Confirm the diagnosis. Assess severity. Treat the disease. Educate patient. And finally, follow the patient over time. Because medicine is not about finding one abnormal test. It is about connecting the dots. Over the next 50 cases, we will put this approach into practice. From pleural effusion to tuberculosis. From asthma to COPD. From pulmonary embolism to interstitial lung disease. From lung cancer to respiratory failure. Each case will challenge you. Each case will teach you. Each make a pulmonologist. Welcome to the Pulmocare Pulmonology Clinical Case Masterclass. 50 cases. One systematic approach. One goal, to transform clinical knowledge into clinical reasoning. Don't just memorize the diagnosis. Understand the journey that leads to it. This is respiratory medicine. One clinical case at a time.